Audrey Lane, and I am looking forward to talking to you tonight about recognizing calciphylaxis. So a little bit of background. Calciphylaxis is the deposition of calcium and phosphorus in the intima of blood vessels. It results in decreased nutrient diffusion and microinfarcts. The one-year mortality can range from 33% to 80%, with those who present with ulcerating lesions having the highest mortality. This really highlights the importance of recognizing it at an earlier stage, because a recent case series actually described complete resolution without reoccurrence in those who were recognized at an early stage and received multidisciplinary treatment. Our patient was a 57-year-old female. She was brought to the emergency department for altered mental status and right lower extremity pain. She'd been hospitalized 3 weeks prior for cellulitis and received antibiotics for this. She did not attend her follow-up appointment and had missed multiple consecutive dialysis appointments, including the 2 immediately prior to this admission. Past medical history was remarkable for end-stage renal disease, type 2 diabetes, HIV infection, depression, and a variety of other things. Her medication list was pretty extensive as well. On physical exam, her vitals were remarkable for hypertension and an elevated BMI. As I mentioned, her mental status wasn't great. She was answering yes or no questions and communicating how painful this leg was, and that was about it. And then when examined, there was a 6x5 indurated plaque on her right leg. The induration was similar to peripheral edema, but unique in that it was limited to this area, and when you pressed on it, it was almost more crunchy. She had a similar but smaller lesion on her left leg. Initial laboratory evaluation was remarkable for many electrolyte disturbances, as you might expect with someone who had missed dialysis. Also remarkable for a low vitamin D, as well as the low CD4 count, showing that her HIV infection had progressed to AIDS. We went ahead and ordered an ultrasound of the lesion on her leg. What the results of the ultrasound showed was really a limitation of the imaging of the tissue because of what they described as large calcification or calcification in this area. Because of this, we pursued a biopsy. The biopsy showed fat necrosis with extensive calcification, the calcification being both interstitially and in some areas present around small blood vessels. In this image, which is not from this patient, you can see the calcification here within the soft tissue. This biopsy confirmed the diagnosis of calciphylaxis. All right, moving on to the discussion. So in fact, 73% of people who are eventually diagnosed with calciphylaxis are initially misdiagnosed. Some of the other things that can present similarly would be cellulitis. One of the distinguishing features of this is that it's not going to respond to antibiotics, and also the pain out of proportion to exam. Finally, the characteristic induration of calciphylaxis is another useful thing to differentiate it from cellulitis. In this patient, we were also concerned for systemic fungal infection given her status as AIDS. And other things to consider would be peripheral arterial disease, vasculitis, and then a variety of other diagnoses that may be appropriate in the clinical context. Understanding the pathogenesis of calciphylaxis provides a really useful framework to understand its risk factors. So with calciphylaxis, when the levels of calcium, phosphorus, and PTH are persistently elevated, the smooth muscle cells within the medial layer of blood vessels become osteoblast-like, and they start producing hydroxyapatite crystals and really depositing within there. This can further progress to fibrosis of the intima, and these two together increase the likelihood that you're going to form a thrombus within these small blood vessels. Understanding this, it seems intuitive that having hyperphosphatemia, hypercalcemia, hyperparathyroidism would all result in being a risk factor for calciphylaxis. And then given that the role that thrombus plays in its progression, it also is intuitive that those who are female, have diabetes, and are obese would be at a higher risk. The treatment of calciphylaxis focuses on limiting further calcification of blood vessels. This means optimizing electrolyte levels and PTH levels. This may include switching from peritoneal dialysis to hemodialysis, and can also include medical or surgical parathyroidectomy. Next, there are some options for promoting decalcification, specifically sodium thiosulfate. This can be given as an infusion following dialysis, and it can also be directly injected into the lesion. Finally, also recommending the use of direct-acting oral anticoagulants. Try to avoid warfarin in these patients because of the role that vitamin K can play in the further progression. Finally, calciphylaxis is extremely painful, so it's really important to have good wound care and pain management for these patients. So for our patient, her encephalopathy resolved with dialysis. When she was improved, we discharged her to home. Unfortunately, she had inconsistent follow-up. She missed multiple consecutive dialysis treatments. When she was seen by her primary care provider approximately 3 weeks after discharge, the area on the right lower calf had more than tripled in size. Here are some of my references, and I thank you for listening to me. I'll take any questions.